Hello, hello, and welcome to Talking All Things Cardiopulm. I am your host, Dr. Rachel Barisi. Today's episode is sponsored by Jane, a clinic management software and EMR. The Jane team knows that when your workday is spent providing care to your patients, it can feel like there aren't enough hours in the day for the rest of your administrative tasks. This can mean that scheduling appointments becomes an after-hours task, turning what should be restful evenings into extra-long workdays. That's why Jane has designed a user-friendly online booking page so you can give your patients the freedom to book their appointments at their own convenience, whether that's after hours or on the weekends. Patients can also manage their appointments, fill out intake forms, and enable SMS and email reminders from their secure online portal, which saves you from having to do it manually. To see how Jane can help you reclaim your evenings and weekends, head to the show notes and click on the link to book a personalized demo. Or if you're ready to get started, use code CardioPulm1MO at the time of sign up for a 1-month grace period applied. Thanks again, Jane. All right, welcome. We are in the second week of August, and I'm just going to keep saying it. We are speeding through this year. Costco's already got Halloween out. We have pumpkin beer out. And I say it every year, don't rush my life. It's not time yet. I appreciate all the seasons. I love me some fall, but do not rush my summer. So it's moving fast. I'm going to be heading home this week back to the East Coast, hopefully get some beach time. That is the big hopeful goal. And of course, see the fam. So going to be a good week and just hoping for some good weather. All right, so I wanted to actually have a few things on my list of podcasts, and so I really couldn't decide what I wanted to talk about today. I have two other topics that I think I'm going to leave until next week and the week after. Just requires a little bit more setup. I'm not sure if one will translate well to podcast because it's going to be more visual, so I have to decide if that's a good idea or not, and I'm going to play with that a little bit. So what we are going to talk about today is a case, and I had a really fun case just the other day, and I always get excited when I get my respiratory mucus patient. So I haven't talked about this specific patient yet, and I think it's a good conversation to start, whether you're in the acute care setting or sitting for the CCS, and even if you are a DPT student, this can be very helpful for you. So I had an older patient. She was an 89-year-old female. She had a relatively complex past medical history, but the short of it was heart disease, HFpEF, so she has heart failure with preserved EF. She is diabetic type 1, has a history of hypertension, hyperlipidemia, hypothyroid, and she was admitted for acute hypoxic respiratory failure. So essentially they were trying to confirm whether it was solely heart failure exacerbation versus pneumonia with superimposed heart failure exacerbation. And she had already been here for a few days before I had come in. She actually was supposed to be going down for a test that morning, but they sent her back up because her respiratory status was declining. She was on a little bit more oxygen. She was consistently coughing, and they decided it wasn't safe. So she was actually on the floor. And when I came into the room, she just, she was exhausted. And you could tell that she wasn't going to be into doing physical therapy for the day. But I really wanted to make a point that we were going to spend some more time working on her breathing and her coughing, because that was her primary problem in this moment. She's on more oxygen. Her sats were okay, like low 90s. She was on 1 to 2 liters. I think she was on 1 liter when I came, or 2 liters when I came in. And I think we were able to down her to 1 once her breathing was calmed down a little bit. And the one thing that she was complaining of was this cough. She said she had an awful night. I can't stop coughing. And so, you could tell there was some anxiety, some fear wrapped around that. And what was most significant about her cough, besides the fact that it was wet and junky and congested, like we can use all of the adjectives to describe this wet cough, but she significantly lacked phase 1 and 2 of her cough. So she had basically no inhale and there was no glottal closure. She was essentially just stuck in this phase 4 expulsion phase. So she just was, and when you're only on expulsion and you're not performing the inhale, you're not getting the glottal closure, the cough becomes less and less effective. And she was clearly fatiguing. And so you can tell there was some fear kind of surrounding all this, that she wasn't going to be able to catch her breath. And so just a little background, within the day or two before seeing her, they actually started looking at her sputum. So they did a sputum collection and it was growing Aspergillus. And so just kind of a big trigger word, if you see Aspergillus, that is a fungal infection. So fungal pneumonia is not easy to treat because fungus is not easy to treat. This might be a gross analogy, but think about people who have athlete's foot. It's recurring, it comes back, people can't get rid of it. And part of the problem is that there aren't a ton of antifungal medications that really can help said infection. It's not like bacteria where we can find the specific bacteria. We have the correct antibiotic for that bacteria and it will rid itself, right? Fungal infections are hard to treat. And I remember when I was studying for my CCS, I believe there was one antifungal med available at that time. Apparently there's about 3 now, but antifungal meds are very harsh medications. So they're very aggressive to the system. They have a lot of interdrug reaction, and they also can affect the kidneys and the livers, you have one, liver significantly. So if you have a complex past medical history, you might have significant limitation on even trying any of these medications if it's going to either interact with another drug or, cause harm to, say, your kidneys and you have a history of kidney disease. The other piece of it is fungal infections can cause cavitation in the lung. So essentially it causes necrotizing of the parenchyma. And so you literally get breakdown of the tissue itself. And again, super hard to treat. Sometimes they can do a resection if it's getting, if it's starting to spread too much, but it's going to cause a fibrotic appearance long term. Diagnosing a fungal pneumonia is also not, just like a quick thing, because it's not, unless you're testing the sputum, it's a harder thing to recognize on CT and chest x-ray because it can look like other things. So part of the process of after having fungal pneumonia is actually having a team that's familiar with the case, especially even the radiologist, so that they can kind of track it, is what the literature says. So just a really difficult infection to treat, very commonly seen in immunocompromised patients. And what is interesting is that I have noticed that I'm seeing more and more Aspergillus infections. Really never thought anything of it, but there is also an association with having COVID and then later on getting something like Aspergillus pneumonia. So I don't know exactly what that correlation is yet. But that seems to be an increasing number of Aspergillus post-COVID infection. So that is just an interesting thing to kind of dig into next, because I definitely have been seeing more and more of these patients, which you usually get like one every now and again. So she has heart failure exacerbation. She has hypoxic respiratory failure. So she's requiring some oxygen, not high level, but more than before. And she has this wet, productive cough, and it is consistent. It's a persistent cough. So this is just kind of one of those things I want to bring up where I'm treating in the acute care setting And my main focus for this session was not mobility. We did some mobility, but that was not the focus of this session. The focus of the session was to try to help decrease this persistent cough, improve oxygenation, give her some strategies to have a more effective cough, and potentially help mobilize said secretions. So this is super fun for me. This is like if you had to pick your avatar of a perfect patient, this is one of my favorite patients to treat, because you can make so much difference for this person with the interventions that you perform. So from an assessment perspective, I'm auscultating. I believe on CT mentioned anterior right upper lobe, right middle lobe having consolidation. So just wanted to kind of double check, but she had rhonchi significantly throughout anterior left upper lobe and most in right upper lobe, right middle lobe. And then her posterior aspects were severely diminished, like minimal air movement at all. I already told you about her cough. Her cough was wet, it was junky, and it severely lacked phase 1 and 2 of a cough. She was basically stuck in this expulsion phase, and it was just not effective. She wasn't getting anything out. She was in a persistent cough. She was kind of getting panicky from it, and she was clearly exhausted. We also did I did a little bit of a chest wall assessment. I really wanted to get into intervention for her, but I wanted to see. So she definitely had decreased right lateral costal movement versus left. More so, she had decreased on the right. Just really poor lateral movement, period. She was really stuck in this apical breathing pattern. She had a lot of accessory muscle use going on. She wasn't kicking in diaphragm much. And obviously so, because she is short of breath, she's fatiguing. And the anxiety is spiraling this. And she actually talked about it. She said, I feel so nervous. It's making my shortness of breath worse. So before we did anything, we just started with some simple breathing strategies. I had her inhale through her nose without any specific counts and exhale through pursed lips. Now, although COPD is not in her history, I still utilized pursed lips on exhalation to help decrease the resistance of her exhale, and also improve the time of her exhale. And it's also known to help with anxiety. So inhaling through the nose, we have oxygen in the nose. We're activating our diaphragm a little bit more versus getting stuck in that panting open mouth breathing pattern, and extending exhale. Once we were calmed down a bit, I moved into an inspiratory hold, because when we use inspiratory holds for mucus, it can actually help get air behind that mucus and help move said mucus out. And sometimes if you have a patient that has a lot of mucus, if you get them to do an inspiratory hold, sometimes it kicks them straight into a cough. The other piece of an inspiratory hold, and I think I've talked about this on a past episode, is that it resembles or mirrors the first two phases of a cough, which is what she's missing. So we're going to inhale and we're going to hold, and we're going to work on that sequencing, because clearly, besides the fatigue being an aspect of this, we have like a poor sequencing with her cough technique. So then we moved into just a simple 1 second in, 1 second hold, 2 seconds out. She was pretty calm with that, so I moved her into a 2-2-4, so 2 seconds in, 2 second hold, 4 seconds out. And we did this just for a little while. I tried to see if I could do some paired breathing with exercises in the bed, but as soon as she started to pair her breath with her movement, she kicked her right into a cough. So I ixnayed the thorax until we got the breathing, coughing under control. she had a PEP device in the room, and when I came in, she was actually using it, but it wasn't really getting her past that next step because she was still kind of stuck in this exhalation, expulsion phase. And in the pulmonology notes, one of the commentary was that they wanted aggressive chest PT. So that's a story for another day. I think using the word aggressive for anything is like a pet peeve of mine in the acute care setting. We're not doing aggressive chest PT. We're not doing aggressive PT. We're not doing aggressive elevation because I saw that one the other day. But they wanted more hands-on. Um, um, what's the word I want to use? Percussion, vibration type interventions. So that's what we did. So I asked her if she ever had percussion done before. She said no. I explained what we were going to do. She was okay with it. I showed her what it would feel like. I started with a lighter percussion and then increased a bit. And I used padding. So big easy thing that you can do when you're trying to do percussion on a patient is actually fold a pillowcase. And you can get up to like 4 to 6 layers. And so especially if you have someone who's a little bit more cachectic, a little bit more frail, you can give them a little bit of padding. And so she had very pronounced clavicles, very pronounced ribs. And so I really wanted to make sure that we weren't causing more harm than good. And then before I actually started that, I jumped into the hallway because I knew her nurse was outside, and I just gave her a heads up that I was going to be doing percussion to her lungs because she's on telly. And so something that you should know, and I think, again, I have mentioned this before, is if you're doing percussion over a telly lead, it can show up as VTAC on telemetry. So I think it's just the movement of the activity, the pounding on the chest creates an erroneous rhythm. And so definitely want to give them a heads up before, anything else. And I also had the telepack on while I was working with her, as well as the pulse ox on. An inappropriate response to percussion is actually a drop in pulse ox. And so we would say greater than 4% is inappropriate. And so you want to make sure that you're monitoring SATs while doing something like this. And also watching your patient. How are they feeling? So she did really well with it. We had her working on breathing as I was percussing. And I basically did anterior, right, and left with her in the semi-Fowler position, which is actually the appropriate postural drainage position. And I did not put her in prone to do posterior aspects, but I did upper apical on both sides as well. And in the sitting position, we did vibration anterior and posterior together. That's my favorite vibration move. You just get a nice, it's a nice handhold technique where you're kind of getting the most bang for your buck. You're getting anterior and posterior. It's an easy leverage position and typically gets good results. So percussion is performed throughout the entire breathing pattern. Vibration is typically performed solely through exhalation. That's textbook. Sometimes you can play with, getting a little bit of vibration on an inhale too. But from a textbook perspective, vibration is performed only through exhalation. And then we actually worked on her cough technique. So I started her with a huff cough, just because I wanted to give her a different variety and see if that would change things up and actually get things moving. And, a lot of people have a hard time with the technique. I don't know if it's because it's a strange thing to do. You've never had to, say the word huff and then make this like airy, huffy sound. Some people find it funny and, just really can't execute it. But I find that patients that have a hard time either sequencing their cough or coughing on command can typically huff on command. And she did perfect. It was like textbook huff. I wanted so badly to record her huffing because it was perfect. And she was able to actually do different velocity huffs, and she was productive. The huff, especially the first one, kicked her into a cough. And so that made her a little nervous in the beginning. But what we did was actually work on our cough technique. And so the biggest thing that we concentrated on was just taking a big inhale before going for the cough. I didn't even really, cue her on the hold. It kind of happened on its own, which is super helpful sometimes. And she huffed. It put her into a cough. She listened to the cue, and she got, a good amount of mucus out, which was fantastic. When we were working on her breathing and her coughing stopped. So she was in this like coughing fit when I walked in, and she couldn't get out of expulsion. When we started incorporating breathing, it slowed down. When I incorporated the huff with a controlled cough, it slowed down. It didn't kick her into a coughing fit. It actually was a productive cough, and it settled it down. The one thing I do want to say, just in general, is if you're going to do percussion and vibration, and you have someone who has this persistent cough, you have to make sure that you don't overdo it either. I usually say reps of 3 to 5 is like my happy zone with breathing techniques, because it can make patients anxious. They might get more shorter breath. Their sequencing might get funky. And a big one with coughing is that it can actually create like a vagal reflex. And so you don't want to have them accidentally like become hypotensive because you over cough. So you just have to be like careful. Don't overdo. So it's a little on the gas, off the gas, on the gas, off the gas, and really pay attention to how your person is doing. She was doing great. Her oxygen sats were actually increasing. When I left, she was at 99%, which is why I turned her to 1 from 2, and she was staying at that 98, 99 when I walked out the door. And after we did all that, then we did a little bit of mobility in the room. We did 1 to 2 laps, and then we got to the chair, and she actually ordered some food since she was going for a test. She didn't have breakfast yet, but she felt she couldn't eat because she was like stuck in this coughing pattern. So then we also talked about the importance of getting good nutrition and protein for healing and such. So it was a super effective session. And like I said, the focus of my session was not walking the patient. The focus of my session was improving her breathing sequence, teaching her how to control her breath, putting her in the driver's seat of this really strenuous, anxious time, and also giving her cues on actually how to improve her cough so it can be effective and fatigue her less. So that was really important for her in that moment, more than walking X number of feet. She was pleasantly surprised with our session, because when she originally saw me, she was like, I really don't think we can do this right now. When she realized that I was there to help her with this piece of her picture, she was more than accepting and very engaged in the whole thing. And she was sitting up in the chair and looked calm when I walked out that door. So she was very appreciative. She was just super pocket size. She was so cute. But this is like my avatar. This is that perfect patient that, if I can say, like, this is one of the patient types that I love to treat, it's this one, because you can make so much improvement in such a short period of time. Oh, the other thing was I auscultated after said breathing exercises, percussion vibration, cough techniques, productive cough. She had less rhonchi in both anterior right and left upper lobes, and she actually had some air movement posteriorly. It was still diminished, but there was actually air moving, which is huge. And we can see that her O2 sats had significantly improved too. So there's just so much benefit in utilizing breathing techniques, airway clearance techniques with this patient population. If I was able to see her again, the next thing would be incorporating more paired breathing with Therex. We did some pace breathing with ambulation in the room, but that wasn't the big focus of the session, but that would be the next big piece. And then interval walking, so that when we're increasing ambulation, we're not just going for distance, we're going for distance with appropriate rest breaks, with appropriate pacing, so on and so forth. So I wish I was able to see her again, but I was super, super excited to have this patient. She did so great. And when a patient nails a huff cough, it's everything. It's 100% everything to me. So she was a complete joy. And yeah, I'm just going to put another plug in. Do breathing exercises, do airway clearance techniques, feel empowered to teach patients how to cough appropriately, because that is going to help the mobility piece. Okay. It's just such an important piece to this whole clinical picture. And we should be a part of that piece, a part of that picture. And it shouldn't be a surprise either that, we're helping with that. So little by little, more of us that are doing these things, the more common it will become, and the more patients we can help, which is really the end game here. All right. So we hit a whole bunch of things today. We talked about Aspergillus, fungal pneumonia. We talked about some of the interventions are really hard to come by from a long-term perspective, from a medication perspective. But when you're looking at this patient from a PT perspective, you are looking at that chest exam. You are focusing on breathing exercises, you're focusing on airway clearance techniques and doing everything to clear said mucus so that the patient will have improved gas exchange and therefore be able to do more and better with less anxiety and less shortness of breath. All right, I hope that was super helpful for you. If you got anything out of this podcast, please drop me some stars, write a great review. It is highly appreciated. I hope you all have a wonderful day, and whatever you have to do, get after it.